Hello, everyone, and welcome to the IHER seminar series. My name is Lynn Richardson. I'm the co-director of the Institute for Health Equity Research. And it is my pleasure to introduce our guest speaker. Dr. John Rich is the director of the Rush VMO Institute for Health Equity at Rush University Medical Center in Chicago. And I think he's going to tell us a little bit more about that. Prior to going to Rush for a long time, he was at Drexel University in the School of Public Health. And John's research has focused on issues of urban violence, trauma, and health inequities. There's a long bio, which hopefully you all received with the invitation to this talk. But I do need to call out that John is my fellow co-alum from the AAMC Health Services Research Institute. So 3-4 decades ago, we were young investigators learning health services research together. So it's my very great pleasure to welcome him here to IHER. And I'm sure you're all as excited as I am to hear his talk. Understanding racial trauma and leaning into complexity. And he's going to help us imagine new pathways toward health equity. If you have questions, there is a Q&A feature. If you could put your questions into the Q&A, we hope that we'll be able to get to as many of them as we can at the end of Dr. Rich's talk. So John, please. Yeah, we'll do another hug. We're so glad you're here. Thank you for coming. Should have mentioned one other thing about John, but I'll leave it there. I knew him before the MacArthur Foundation decided he was a genius.
So I'll never forget the day that I was walking in the hallway at Boston City Hospital and in the early 90s, and I ran into my colleague and friend, Dr. Jonathan Woodson. Jonathan was a surgeon, a vascular surgeon and trauma surgeon who had trained at Mass General, and we were there at the same time. And that day, he was particularly frustrated. And I ran into him in the stairwell. He said, you know, we've got to do something. All these young Black men are coming in shot. We take them to the operating room. We're able to repair their wounds. And they sit for days, sometimes weeks on the surgical service. And nothing happens. No one talks to them. And he said, you know, that happened. The reason it's in me right now, he said, is because there was a young man that I treated a month or so ago. We saved his life. It was close, but we saved his life. But this morning, I'm coming in my car, and I hear on the radio that that young man is dead. And we called that an epidemic of violence. We were also in the midst of an HIV epidemic for which we had no effective treatments at the time. And it was also disproportionately impacting these same young people. So Jonathan said, we got to do something. Somebody's got to go talk to these young people, help them understand the danger that they're in. And so I thought, you know, that I felt some of that same pain. Both of us as Black physicians, we trained in Boston, but had grown up in New York. And so I set out to spend some time talking to young people who were on the surgical service. And I began to spend time with them, hearing their stories. And it took me a while to realize it, but I came to understand that there was a general sense among the providers who cared for these young people that young Black men didn't just get shot, they got themselves shot. There was a kind of implicit, lingering blame that was assigned to them for their own injuries. It's not unfamiliar to many of you who do work where it's just somehow in the atmosphere that we attribute blame to the people who are most affected by illness and injury. And I realized that I too held that part of that bias, perhaps not to the same degree, but there was something that made me think, well, maybe there was something they were doing wrong. Maybe they could do something different. To some extent, ignoring the context in which these young people live. And so, as part of the research that I undertook, I spent time not only in the clinic that I had started, a young men's health clinic at Boston City Hospital, but also in qualitative research, hearing the stories of these young people, identifying methods for analyzing this qualitative data, trying to harness my own experience while also bracketing my experience and respecting the fact that my experience in life was different. And I hope today to share with you some of what I learned, and some of it in the words of the young people who are most affected. And I'll say that that's one of the reasons I'm so glad to be here today, to be here with you, Dr. Richardson, you, Dr. Horowitz, all my friends, because you have been instrumental in my learning and having a community that not only thinks about how we address the issues of individuals, but how we understand the context and the power and the strength of the communities in which people live. Now, I wanted to just take a step back and talk for a moment about post-traumatic stress disorder, which I'm sure many of you know in detail. I'll simply say that it has 4 components. Hyperarousal or hyperactivity, that's that jumpy feeling, the inability to be settled, jitteriness, inability to sleep that is often so intrusive in the lives of people who have had psychological trauma. There's re-experiencing and intrusive symptoms. That's nightmares, flashbacks, and also body memories. So sensations or pains that occur when you're triggered and reminded of the event. There's emotional numbing, and this is one that we don't talk about as much, but for many of the young people that I met, it even entails the loss of the ability to feel fear, the loss of the ability to feel love, as though those emotions are no longer available, and often some other emotion fills its place. And then negative alteration in cognition and mood, so difficulty concentrating and depression. And so when we think about these in the context of other types of, well, we think about it mostly in the context of returning combat veterans who have been terribly wounded by the experiences there. Less so, I think, have we been attentive to it for victims of sexual violence. It was almost off the radar screen entirely for young urban victims of violence. And so the question is, what does it look like in that setting? How does the context impact what we see and how we judge it when we see it? And so I want to introduce you to David. David is a young man who I met when he was a participant in a program in Philadelphia called Healing Hurt People, which I'll tell you just a little bit about in a moment. But it really attempts to engage young people toward healing their wounds of trauma. As a part of that program, we engage these young people in a digital story workshop where they produce their story in their words with the images that they'd like to have alongside it. And so I'd like to show that to you, and I'd ask you if you would indulge me by, if there's some phrase that sticks in your mind, I'm just going to ask you afterwards just to say it out loud, okay? So this is David Green.
Depression.
None of the people I knew in the sandbox is alive today.
I was shooting basketball with friends at the playground the first time I saw someone get shot. It was random. I didn't think something like that would happen to me or my family. I have seen a lot. Now I don't sleep at nights. Last year my cousin was killed at home in his bed. While everyone is sleeping, I stay awake. I go to sleep in the morning when people are up and moving around. When I do sleep, I have nightmares. Sometimes I wake up crying, feeling lonely, wanting revenge. I wake up paranoid. But there was something that really hurt me, even more than when I got shot 3 times. I was sitting in the street with my brother's head in my lap. Dude stood over him holding a gun before running away. Dude just left. There was nothing I could do. My brother wanted me to hold him. I was crying, panicking. He said, "I'm going to be all right." Little did he know, he wasn't. After that, I knew I would get shot. I started imagining how it would be and how I would hold my body so that they wouldn't shoot me in my heart or my head. When walking in the streets, I would think about how to turn my body so that the bullet would hit my shoulders and not my heart, or how I would use my hands and arms to shield my head. I'm always looking back over my shoulder at my own shadow, hoping that one day I will stop focusing on my past, but looking ahead to my future.
What did you hear? Any words or phrases that stuck with you?
At the end, I heard hope.
Hope.
I heard pain, so much pain.
Pain.
Random.
Random.
Fear.
Fear.
Sandbox really set the frame.
Sandbox. None of the people I knew in the sandbox is alive today.
When he talked about sleeping, when people were awake and everyone was walking around him, that really struck me.
Do you remember why?
It felt like that might be the only time they felt like they could safely go to sleep. They couldn't sleep at night, but during the day when the world was moving, that's when they could rest.
Thank you. Thank you for holding his words. So I'll walk you through some of the pieces there, which you may have been able to hear. He said, none of the people I knew in the sandbox is alive today. My cousin was shot while he was lying in his bed, also related to his pain, I think. That's why I don't sleep at night. I have nightmares. I wake up crying, feeling lonely, wanting revenge. My brother wanted me to hold him. I was crying, panicking. After that, I knew I would get shot. And so if we track this back to what we know about post-traumatic stress, we know that there's an accumulated trauma that leads to hyperarousal, depression, re-experiencing war trauma, and then this kind of hyper-aroused reenactment of the pain. Now, it's also important to think about how this young person's symptoms might be interpreted in a healthcare setting. It turns out that some of this numbness that young people evidence after they've been injured, I have seen interpreted by healthcare providers as, well, he's not telling the truth because he's telling me this terrible story, but he's just numb. There's no emotion attached to it, right? Or the jumpiness. What did you do? You think somebody's out to get you? So without a trauma-informed lens on this, and with the already built-in biases, this post-traumatic stress may actually work against you in getting the care you need. And that was something that came out of the stories of these young people who recounted their experiences. Not by any means were all their experiences bad in the healthcare system, but there were a significant number where they were trying to justify who they were as human beings in the context of what was expected of them, and how they were viewed. So this matters, as you know. Studies that have looked at people who have suffered a penetrating injury, followed them 5 years, found that there was a 44% recurrence of penetrating injury and a 5-year mortality of 20%. And that's unacceptable for any disease or medical problem. But it speaks to the recurrent nature, the chronic recurrent nature of violence, and why it is a problem the healthcare system has to pay attention to. Now, if we try and put together, based on research that I've done and have published on, how does this all work together? What are the pathways, potential pathways from injury to re-injury? Because one set of assumptions might be, well, this is a bad guy, he's out there doing bad stuff, he gets shot, he comes in, he's treated, he goes back out, does more bad stuff, gets shot again. That's kind of the narrative that maybe is woven for us in television or others. But when we began to try and put this together, one other pathway, so there's not only one pathway, presumably, but one would be that a young person is injured. They have post-traumatic stress disorder with all of the things that I told you about. But because of how they're viewed, no one orients them to the fact that this may be what happens in the days and weeks after their injury. Without access to primary care, often without access to insurance, these young people use what is in their environment to treat their distress. And cannabis is a logical choice. Often, young people reported that they used it differently after they were injured. So they'd save it and smoke right before they went to bed as a way to keep the nightmares away. Well, what happens if you're using cannabis? Well, entry-level jobs are off the table. If you have a job, you may lose it. If you're on probation, you may be remanded. And so this begins a cascade that often, we believe, drives young people into illicit economies in order to survive. On the other arc, we know that many young people of color do not trust the police. And so if you're concerned that someone is out to get you, if there's some issue in the community, the police aren't going to be first on the list. And there's pressure. We wrote about it as it's kind of the meaning of being a sucker, but there's the idea that if someone does something to you and you don't respond, then that sends a message to others that they can victimize you without consequence. So there's pressure to do something to keep yourself safe, but the police are not that answer. And we know then that young people often may turn to firearms, other weapons. That is a risk for incarceration or death. Now, sometimes people have said to me, I can't believe you're making excuses for these young people. And I reject that. These are not excuses, these are explanations. I think it's a terrible idea for anyone to have a firearm, but I understand the logic here that would lead to that. And if I can enter into a relationship with a person, a client, a patient, understanding the underlying explanatory theory or logic, then I have a much better opportunity to have a human interaction that's meaningful and impactful. in my view. Now, part of this is also the notion of racial trauma. So we talk about psychological trauma, talk about physical trauma, but how should we be thinking about racial trauma? And for this, I lean on a colleague of mine, Dr. Kenneth Hardy, who has written and taught extensively about the wounds of racial trauma. And he says often that racial oppression is a traumatic form of interpersonal violence which can lacerate the spirit, scar the soul, and puncture the psyche. More specifically, he identifies at least 4 wounds of racial trauma. The first is internalized devaluation. That is, everything that the world tells you about your unworthiness makes you hyper-vigilant, often about respect, because you hear these devaluing messages, dehumanizing messages. The second is an assaulted sense of self. That is, the way that these accumulated messages land on you makes it difficult to figure out who you really are in the world. Of course, critical in the developmental process for adolescents is figuring out who you are in the world. So if you have this assaulted sense of self because of internalized devaluation, where does that leave you? The third is internalized voicelessness. So that is the way in which one's ability to defend against the barrage of unwelcome, negative, and debilitating messages is judged as a troublemaker, angry. And so there's a tendency, because of racial trauma, just to kind of tamp down one's voice as a way of keeping one's head down. And then rage. And he would argue that rage and anger are quite different, that anger is a momentary reaction to an event. Rage is a deeper sense of pushback against these kinds of wounds. The hopeful part of this is that there are ways that we can heal from racial trauma. So to counteract internalized devaluation requires affirmation and acknowledgement so that young people feel seen, that they feel recognized, a general understanding and an acceptance that race is part of what's happening in their lives. Creating a space for race, that is allowing for conversations where we can raise the issue of race without it being a grenade or kind of the race card, which is often a way to push back against that. Racial storytelling, so engaging with one another in stories about our own racial socialization. What was it like growing up? What did you talk about with regard to race in your family of origin? How might that affect the way that you interact with the world? And then finally, rechanneling rage. How do we identify ways for us to, with culturally responsive healing practices, rechannel that rage, either toward healing through movement, through music, through connection to treasured rituals within our cultural identity, that it isn't all about a clinical experience, although it may be, but how do we begin to use that? And so what we've done is to have Ken come to Rush. We engaged 40 leaders in emergency medicine and in the Institute for Health Equity. A total of 16 hours, 4 4-hour sessions, face-to-face, no PowerPoints, just engaging with one another with a skilled facilitator. And it's very powerful. It's very powerful as setting the standard. And I would argue, at least in my experience, that this is an inside-out process. That we can try and address health equity and racism in the world only after we've done our own kind of internal work, understanding what we're holding. Ken talks about it as seeing, being, and doing. The seeing is understanding that racism is a real thing by engaging with people who can tell you about, who have permission in that space to tell you about their lived experience. The being is that self-interrogation where we start to ask ourselves questions. And then the doing. to try and do the doing before doing the seeing and the being could be dangerous even, he would argue, as a therapist. And so I highly recommend his book that came out actually just last month. Focused a little bit towards therapists, but I think the underlying focus of all of his work is how do we engage across issues of race? Not confrontation, but engagement in a way that is safe, but not always comfortable. And so part of what has been meaningful to me is in this practice called Healing Hurt People, a violence intervention program that's trauma informed. We have incorporated, and this is really in Philadelphia, incorporated not only psychological trauma, but racial trauma in our training for our community health worker peers and for our social workers who do this work. And it's been replicated at Stroger County Hospital in Chicago. We're currently working to replicate a version of it at RUSH. RUSH is not a level 1 trauma center, but to make sure that we're meeting the needs of folks whose trauma is less acute, but nonetheless painful. A key part of this has been engaging young people who've had that experience as community health worker peers. And so with support from the Department of Justice, we launched a community health worker peer training academy. And it's been transformative in terms of our understanding so that young people can bring their experience of racial trauma and psychological trauma and come as healers who are doing their own work. More importantly is that we've been able to get behavioral health Medicaid to reimburse for the services of social workers and community health workers at the same rate, recognizing how powerful they are. It's not a great rate, but it's the same rate. So maybe equality, not equity, something like that. And so I think where I land is that there is a complexity here. When we oversimplify the experience, and I was guilty of this, oversimplifying the experience of young people whose lives were not like my own. These were often Black people, but my experience as a Black person and the identities, the multiple identities that I bring were different. And so how do we lean into that complexity? How do we understand it in our work and our research? So I'm gonna kind of shift a little bit to talk about a relatively novel research approach that I'd love your thoughts about, that I think helps to incorporate complexity. So I would say that in my life as a researcher, qualitative researcher, policy researcher, I'm often dealing with cases. I may not be dealing with hundreds of cases, but I'm looking for themes that run throughout these so I can really understand in a deep way the experience of the participants. Sometimes looking at what components of an intervention lead to success. Sometimes as policy researcher thinking about, well, what about differences between states or zip codes or counties? And we always run into the kind of, these are cases and they're relatively small in number. So how do we, on one hand, there's qualitative research methods, and then there are correlational methods, kind of based on Bayesian probability. But how do we use those same methods here, or can we? Well, I argue that there's another set of methods that may be useful here. And part of that is because we're often dealing with these interrelated intersectional factors. So social determinants of health or other social factors which come in bundles. They don't come one at a time, but they come in bundles. And sometimes they require the presence of the other factor in order to exert their effect. And so over time, having some data that are qualitative, some that are quantitative, I kept looking for some way to deal with these and to try and understand in a consistent way how to treat them and how to respect the multiple intersecting identities. And so it was a journey, but I finally have come to learn about something called coincidence analysis. It's a method in a set of methods called configurational comparative methods. They were originally designed in social science, but there are ways that we can use them to model complexity and to bridge qualitative and quantitative approaches. The focus of these methods is on identifying bundles of difference makers in relationship to an outcome. And these are just words on a page, but to really tell you that part of it is that single conditions sometimes exert their effects only in combination with other factors. And I won't say anything more about this. So I want to just present a problem in the study and just a short example of the method and ask you to think a little bit whether this might be useful, because I actually noticed a poster in the back that had that was looking at providers. It was small number 32. How do you begin and identify themes? How might we think about the bridge? So in Philadelphia, in early 2021, or throughout the pandemic, the health department would put this map on the website. And it really displays COVID-19 vaccination rates in Philadelphia. The light blue representing low, the medium blue representing medium, and the dark blue representing high rates. And if you know Philadelphia, you know that these are neighborhoods that are largely, that almost every health problem that affects populations, you would see a pattern like this. And it tends to be neighborhoods that are predominantly Black. But even the more I looked at it, I thought, is that are we calling out race without calling out race? What else could it be? And so at the same time, there were a number of studies that were using social vulnerability. So where we take and create a composite measure of many different factors. And so we had in Philadelphia these social conditions at the zip code level. So measures of economic inequality and racial privilege, the index of concentration of the extremes, for example. Levels of education, overcrowding, service employment, public transit use, health insurance, and limited English proficiency. So one can create a composite index, or one can look at them individually. So using coincidence analysis, I'm happy to talk about the specific details of it, but it's based in Boolean algebra. And you can do the analysis in R, but what's useful is that you can actually see the analysis in a much more interactive, I would argue, and intuitive way. And so we modeled what factors were most closely linked with high consistency to these low COVID vaccination rates at the neighborhood level. And here's what we found. Move this so we can see it fully. It turned out that if you look at those persistently low neighborhoods, so this one here means the presence of persistently low COVID vaccination rates. You'll notice there's a red dotted line, and then below is a 0, which means these are the not persistently low neighborhoods, okay? In yellow, I've marked the combination of conditions that was most closely linked to these low COVID vaccination rates for those neighborhoods. And it turns out that low percentage of people with college education combined with the absence of high racial privilege, okay? So that's largely high concentrations of Black and brown people. Not either one, it has to be the combination of the two. This green line is where since there's noise in all data, this is one case where it has the combination, but it doesn't have the outcome. I won't say these are the measures of fit that are used with this method. I won't go into much detail, but those are high measures of fit. What you can also do with this method is you can model the opposite of the outcome you're looking for. So we looked at those neighborhoods that had not low. Okay. And it turned out, let me first show you the map. So we mapped this, and what you'll see is that brown represents those neighborhoods with low college attainment, green for not high racial privilege, that's medium and low. And the crosshatch is both low college attainment and not high concentrated racial privilege. The zip code labels indicate a neighborhood with low COVID vaccination rates. And what you'll see is almost all of the neighborhoods that have the crosshatch pattern also have the label. And so we see that that's accounting for these combinations. Those are the difference makers together. There are a couple of neighborhoods that have low COVID vaccination rates that are only covered by low racial privilege, and there's one neighborhood that has the combination but does not have low COVID vaccination. Okay? So we're able to model it in a way that's kind of intuitive, and then we can map it. When we looked at not persistently low, it turned out those same factors were active, but they didn't require that they occur together. It was either the absence of low college attainment or the presence of high racial privilege. And so here we've mapped it as well, more complicated to look at. But if you can imagine that this method, because it's looking at difference makers, has the potential to be applied to, for example, factors that lead to successful implementation of an intervention, because we know that there may actually be multiple pathways to successful implementation, or policy implementation at the state level. And we've published on firearm laws, what combinations of firearm laws are most consistently linked to low suicide and homicide rates. And so this was published in BMC Public Health back in 2022. But I raise this because I think that if we're going to move forward, as we move forward, we may need different methods. This is different from correlational methods. It's different from qualitative methods. It's its own thing. And we're looking forward to applying this in our neighborhoods. So I'll show you a graphic of the neighborhoods that Rush serves, but also to think about community partnered theorizing about what's important. So those diagrams are accessible enough so that we could sit in a room with community members and say, what do you think this makes sense? What else, what do you think is missing? When we look at the map, tell me what you know about this zip code or neighborhood or census tract, so that we can begin a more transparent conversation about what the challenges are, how they bunch up, and how we can address them. We're looking forward to engaging trainees, again, not necessarily as the only method or the lead method, but an auxiliary method to give us a different understanding. And we're planning to host an intensive CNA workshop in Chicago in the spring of 2024. We'll let you know more about that soon. So maybe even in complex circumstances like the one I described with David and young people who've been victims, we can find new ways to understand their experience and participate with them in understanding it. So where are we now? These are the neighborhoods on Chicago's west side that Rush looks out onto and that many of our patients hail from. And these are communities that have been historically neglected with significant disinvestment. Rush has historically, since about 2016, made a transparent effort to embrace health equity as a core component of its strategy, and has moved over time to continue to think about how do we improve the health of communities. So in 2017, Rush adopted an anchor mission and was one of the founding members of the Anchor Health Network. In 2018, together with other institutions in Chicago, launched Westside United, which is an organization that's community-led and will spin off as its own nonprofit in the next year, but really serving as the focus of the work to close the life expectancy gap that exists in Chicago, and I know exists in many of the places that we do work and that we think about. And so if you look at Chicago, and I'm learning as relative newcomer, you'll see that since 2010, life expectancy in Chicago has been falling for all groups except white residents. So the green line here is white residents. And since 2010, way pre-COVID, life expectancy has been dropping. In the neighborhoods, most of these are to the west, East Garfield Park, North Lawndale, West Garfield Park, Austin to the west, Inglewood to the south. You see the life expectancy of birth of those communities, as opposed to those communities to the north and to the east, the so-called loop. Post-COVID, this got worse, and so we now see this dramatic 14-year life expectancy gap over what's less than a 5-mile distance. And so the true north that was articulated and becomes ever more elusive yet is to close that life expectancy gap by 50% by 2030. We know that violence is a part of that, a significant part of it, and heart disease, cardiometabolic disease, more broadly, COVID, stroke, diabetes, cancer, and infant mortality, opioid overdose plays a role there. And so one of the questions is, what are the factors that lead to these disease states that are driving life expectancy gaps? And so we're committed to doing this in partnership with community and learning from all of you who've been doing this for a long time. In 2021, Rush launched the BMO Institute for Health Equity with a $10 million gift from the BMO Harris Bank. And it has the mission you see before you: to build, evaluate, and sustain scalable approaches that improve health and eliminate health inequities by integrating community partnerships, clinical practice, education, research, and policy. And the guiding graphic is this 5-petal flower, where we begin to think about how do we leverage the strengths of a university and a health system. So Rush is a university and a health system. So I see a university owned by a health system. And so we have these strengths and power, but we also know that universities and health systems are, the word silo is a word that I hear almost on a daily basis. And so how do we begin to bring together the strengths of community, faculty, staff to make a difference? The Institute vision, which I've distilled down significantly, is really to think about how do we sustain authentic community partnerships and community partnered research to improve health equity. Ensure that every graduate of Rush has sensibilities about racial trauma and has done a level of work to understand structural racism. We're eager to produce this next generation of scholars, practitioners, and educators in health equity, while also redefining who these opportunities are available to. So thinking about how we ensure that there are opportunities, pathways for community members to succeed. And then support equitable clinical practice by redesigning and locating care models in community to reduce the rates of chronic disease. Significantly, Rush joined a partnership of people who were really sick of seeing these problems in the West Garfield Park community, came together in coalition and began to plan for what is called the Sankofa Wellness Village, where there'll be a Sankofa Wellness Center. They pulled together a proposal, they submitted it to the Pritzker Traubert Foundation for the Chicago Prize, a $10 million capital development prize, and won the prize to begin the capital work here. Now, Rush is a part of that, but Rush is helping to provide some capital. But the idea that we can partner in ways where the vision is from community, and this is challenging, of course, because powerful institutions tend to want to exert their power at the table. But bringing together the Y, Erie Health Center, there will be a supermarket as part of this. So these kind of partnerships matter if the foundation is set. But I would also say one of our goals is to develop community partnerships using locations like that to address intergenerational trauma. So I've been in this position for just 9 months. But here are the things that I'm thinking about, and I'd love to have this dialogue with you, is what I said earlier. I think we have to do this as an inside-out process. That this interrogation, thinking about racial trauma is critical as a first step. And I think that one of the challenges is that whatever we do in the world, the question comes back, well, how did it affect our outcomes? And so what's the timeline from doing our own work to seeing these outcomes, and what can we expect? Or is this simply a fundamental investment that we have to make? But that's a question, not an opinion necessarily. That's kind of I would also say that the idea of competition in the health equity space is something we've got to think about. That institutions are often about wanting to achieve and to lead. And yet competition in the health equity space, whether in a city or across states, may be antithetical to what we're trying to achieve. So what do partnerships look like in settings where fiscal sustainability is always out front, right? So the no margin, no mission thinking tends to lead. So what we can hope to do is to begin to disentangle that and begin to understand what is the cost of addressing these root causes of inequity that span across centuries. Breaking down silos is our work to do internally. Those silos exist for a reason. And so my role has been to try and understand and do as much as I can, as much listening as I can to understand where threat has come in, so that the fundamental needs that people have for security may not be met, or may look like when we implement something new, it's inevitably extractive. So trying to put at the forefront that we will not be extracted. We will from the beginning have these principles that are not principles derived from whiteness, but they're principles that we come to together that try and push against the causes of inequity. As I said, intersectional methods have captured my imagination. I'd love to think about how we use them. And then finally, how do we build a movement? I hear the word strategy a ton in the day-to-day, but I think more about movements. And I happen to have the great privilege of being on a webinar a couple of weeks ago where the speaker was Angela Davis. And she's so wise. She said something that I think is important for us to remember, because even in the midst of these data, which can be quite stark and sometimes depressing, right? She said, generating hope is a requirement for a movement. And I believe we are a movement here. Because in her estimation, movements can't go forward unless there's hope. And we build hope by recognizing progress and by recognizing and celebrating our victories. And that took me back for a moment, because I think that there is, in my mind, my own experience, I want to lead with the problem. But I also want to take a moment and acknowledge, in the presence of my colleagues who've been doing this work, all of you have been doing this work for decades, we've made progress, right? We've made progress. It may not be as much progress as we would like, and it may always feel inadequate against this background of structural racism, but if we don't acknowledge the progress, then we can't sustain a movement. And so I hope that together we can find ways to collaborate, to continue to build that next generation by infusing hope, holding some history and then moving forward in the pursuit of health equity. Pleasure to be with you. A pleasure to share some thoughts. I'd love to continue this dialogue for as long as we can, in person or virtually.
Thank you, John. You look like you're on, can you see anything in the Q&A?
A lot of applause emojis, but no questions yet.
So first, thank you, because that was incredible. Thank you. I'm very intrigued by, early on, you talked about a policy change, particularly in reimbursement, albeit not great, but equitable, in thinking about how we move forward, and because ultimately the bottom line is a requirement of essentially anything we do, of how you got to that point and what were some of the key components that really led to that, and how that might be leveraged, or are there lessons from that that we could apply to other kinds of initiatives?
Thank you. So the question is a great one. It's about policy change. And I mentioned a policy change to get reimbursement under Medicaid for hospital-based, or really community-based, intervention for trauma that was coming from a hospital setting. So I will tell you, it took a long time, and it required some champions in the system. So Philadelphia has something of an odd or unique behavioral health infrastructure. It used to be that behavioral health was a part of the health department, but a leader named Estelle Richmond, back, I think in the 80s, demerged them and created behavioral health as its own. And she embedded in it the behavioral health contract agency for Medicaid dollars coming from the state. So that's already something of an unusual mechanism. So the dollars flow, Medicaid dollars on the behavioral health carve out flow to the city, and a city agency is essentially then making policy and contracts. And they had the opportunity to retain, in a value-based scheme, retain some of the savings and then reinvest them. So early on, a champion, Arthur Evans, who's now CEO of the American Psychological Association, we came together and began to talk about this problem and how to solve it. And it was initially grant funded. It was expanded with more and more grant funding to then cover multiple trauma centers. But as things got tighter, there had been some discussions about moving this to reimbursement under Medicaid. And so I think the most important thing was to come to the table with a clear sense of what was happening in the process of serving these young people. Because the initial impulse on the part of the leaders, and I understand it, was to say, let's fit this into an existing model. So there's psych rehab. We'll put this in the psych rehab model. We said, no, this is not that. This will not work. Well, let's make it the crisis intervention. No. And so ultimately, we worked with them to design the model. So that was critical. So just to give you an example, because most of the work was happening in the community, our social workers and community health worker peers would go from the office to the home of a young person in the community. We worked with them to get a reimbursement formula where that time it takes to drive from the office to the patient's home is reimbursable, as long as the patient is there. Or the worker can engage in some productive work on behalf of the client, so-called collateral services. And then, so we had to change our workflow to some extent. We said, okay, well, when you do see a client, don't come back to the office, go to see the next client. So there was some of that changing our workflow to accommodate it, but it really had to do with a system that wanted to figure out a way to make this sustainable. And I think that kind of alignment maybe seems rare, but I'm seeing something similar happen in Illinois now. The more that we realize that one of the driving root causes of violence is the issue of trauma. Now, how do we extrapolate to other? That's one of the questions. So how do we, for example, there's no physical health dollars from Medicaid coming toward this program. So it happened to be aligned in a way that made sense. But I would say some of it relates to how we document processes in a faithful way with respect, paying attention to outcomes, but paying close attention to the how we got there. Because I think that that's what payers can understand. And if we also make an equity argument that these young people ought to be able to access the same services for the same problems as others, I think we may have some momentum. But those are the small lessons I can derive. The reimbursement, and the reimbursement was actually about the highest reimbursement that the behavioral health agency offers. It's not great overall, but it's certainly for the work was huge. And I'd be happy to talk about how else it changed our practice, in some ways for the better, in some ways for the worse, to be honest with you.
A question in the chat. If I can ask, it's from Dr. Rachel Solnick. She says, the CNA approach looking at difference makers is very exciting. What has been your experience in stakeholders' reception to complex data analyses in terms of advocacy? i.e., I'm thinking parallels with complex data analyses to show gerrymandering issues and how communicating unfairness got confused in the complexity.
Say that last part again, how communicating.
How communicating unfairness got confused in the complexity.
So I'm not sure I can answer that last part, but I do want to get back to what may be, can you go back to the question one more time?
Yep. What has been your experience in stakeholders' reception to complex data analyses in terms of advocacy?
Yeah, thank you. That's a really good question. And I don't think we have a lot of experience. The first articles using coincidence analysis were published in 2020.
Mm-hmm.
So right now there are about 60 papers in the literature that have used this as a key method. And I will tell you that writing the papers, you have to do a lot of explaining. So I could say, oh, I did a logistic regression and nobody would bat an eye, but now you gotta really explain what you're doing. And so I think that's good because now there are a set of many others who are doing this work where you have a template. Because it is a slightly different way of knowing, it reminds me of early qualitative methods where there was, the dominant paradigm of knowing that I was inculcated into in my medical, I didn't even know there was anything other than p-values and correlate. I just didn't know. I'm a little miffed about that. All the education I paid for, the philosophy of science didn't really make its way in. And so when I encountered qualitative methods, it opened a whole new world because it opened different ways of knowing that were not always imposed from without, but could be inductive. This is yet a different way, and I think it has some of those same aspects. And so I think it remains to be seen. And I'd be happy to share a paper that I mentioned earlier, which was asking, there had been some conversation about which is the best, what is the incremental contribution of different gun laws over time, or which is the most effective, but they always exist. There are always multiples, some that are there, some that are not there. And so that analysis I think was reasonably well received, but I think we're gonna have to have this next generation of folks who are using this work do that translation better as the method becomes, or these kinds of methods. So coincidence analysis is not the only method in that overarching umbrella, but it solved some of the problems of previous methods. So anyone that wants to know more about that, I'm happy to talk about it and hear your ideas about how it might be helpful.
Thank you for speaking with us. This was really lots to think about. I'm really curious about when you talk about rejecting notions of competition, especially in academia where there is a lot of publish or perish and a lot of competition in that way, which I've also seen due to image in these areas of health equity research. how do you combat that, and how do you make it more of a collaborative atmosphere? What are you working on? What is working for you?
Yeah, I'm still working on it. And I think part of it is to raise the question. Sometimes if we don't actually ask the question. So some of it is internal, and it has to do often with historical maldistribution of resources internally. So when we think about anti-racism, we first start internally, and we might have to encounter historical wounds that people have experienced because they worked a lot on something and somebody else got the credit for it. Or they worked a lot on something and someone else got the money for it. So those things, there is something of an acknowledgement and maybe even some redress for that kind of injustice. So I think it's partly just acknowledging. So I have to be in a university where there's a nursing school that is highly regarded, highly ranked. And yet in a health system, physicians tend to be dominant in that space. And so we have to acknowledge whatever harms that has created. For myself, I think when you put a health equity institute in a place or a health equity center, we have to ask, how is it that this does not replicate those wrongs in one way or another? So I've been intentional to the extent possible, I haven't always gotten it right, about thinking, well, if indirects are a big issue, let's just take that off the table. Like, why would we take indirects? Why would we apply for grants? If there are these other, why wouldn't we do that in concert? How does an institute like this one bring value? What does that value look like internally? While also setting some standards for what we consider health equity work to be, or what we consider to be. And so one of the themes that have come up in this work so far have really been about inclusion and transparency. Maybe transparency first and then inclusion. And so how do we make sure that even as we do budgeting, we're transparent about that? How do we make sure that we, so every seminar series that, and you'll see when I invite you to be seminar speakers, we just have sign language interpretation. It's just there because we're trying to set some standard. Now I know it's not always feasible, but we're trying to just push ourselves a little bit or a lot to think about what does it mean to embody these particular values, and how do we encounter what's difficult about it? Like total inclusion, include everybody is hard. But and we don't always get it right, but if we can push toward that. So that's maybe not a good answer to your question. But I think we just have to, it's somewhat like the undoing racism framework, where you look back and say, well, what went wrong in the past? And maybe an appreciative inquiry perspective where we say, okay, let's talk about what went wrong in the past, but let's talk about a time when it went really well. What did it look like? Because there are always those moments where there's collaboration and folks feel honored and the partnerships really work. And can't we recreate those? But within the new institution, I think it's partly about listening and learning. And many of you who have come into new institutions know that that's probably your first work. But I'm always looking for perspectives that we can potentially collaborate and share.
Can I ask a pointy-headed analytic question? So I'm very curious because I hadn't really heard of the coincidence an analytic approach, but had previously used qualitative comparative analysis, which also used a Boolean approach, which was really helpful to be able to ultimately quantify the qualitative component along with the other quantitatives to look at its impact on the outcome. The challenge that I felt in that analytic approach, which I've loved and thought was really smart, was that it also felt a bit subjective. And in coming up with the different weights, even though I would essentially check them out in a form of member checking, which I thought was sort of the best way I could do it, still felt somewhat subjective. And so I'm curious as to how this approach, whether this approach has that same kind of potential challenge and how you deal with that.
That's a great question. And so that is the approach that I first heard about Charles Reagan developed qualitative comparative analysis out of the same need. In all of these, there's a need to make some judgments about where the cutoffs are. And there are a variety of ways to do it. And so I think one way to think about it is to use multiple approaches where it makes sense and see if the results are robust to those changes. But the main difference between qualitative comparative analysis and I don't know, did you use R to do your analyses? You used FSQCA?
So you're challenging my pre-senile dementia. It's a while ago.
Well, you're right. I mean, there weren't very many
I'd have been asking
approaches.
Yeah, I think, anyway.
But here's the main difference, is that QCA has a top-down approach, which means that if you have 4 factors, you assemble all possible combinations of those factors, right? Of which there are 16, 2 to the K, right? There are 16 combinations of the presence or absence, and then you match the cases to those. But sometimes there aren't enough cases, right? You ran into that, right? So coincidence analysis is bottom up. You take one factor and see if it's sufficient. And then you take pairs of 2 factors and see if they're sufficient. So you never, the whole notion of limited diversity, or counterfactual analysis, or all that, not necessarily transparent stuff, is taken off the table. And there's also a quirk in the QCA algorithm that I'd be happy to talk to you about later that's solved in CNA. And so it's just a step forward, and it's a little bit more, it doesn't back you into a corner sometimes, even if conceptually it's very attractive, but in terms of just making the method work. So I'd love to talk more about it.
Yeah, I'd love to
Yeah.
get your references.
Yeah, I'd actually like to. We'll talk about this later, John, but the question I want to ask now is to have you talk a little bit more about this idea of building a movement. And how do we actually start to operationalize that? We're at a time where lots of institutions now, at least for the moment, are focused on equity and anti-racism, and there are institutes like ours and centers like yours that are doing this work. How do we start to connect, to set common goals, to actually create a movement? I have to admit, I haven't thought about it in terms of a movement for a long time. I haven't thought about what it means to create a movement, but I like your framing, and maybe now is the time. So what are the next steps to that?
So yeah, it's a really good question. And it's more kind of a feeling I have as the public discourse begins to turn more toxic, and health equity, which has always been an idea that we've embraced, suddenly gets caught in this toxic dialogue. What does it mean to stand firm on that? And the problem for all of us is we're within institutions that are also facing lots of challenges and threats, given, and it's often in terms like payer mix, and so we're trying to balance these 2 things. So I think part of the movement is to try and first of all begin to have conversations about what health equity looks like in that space. What are is there, and I know this comes up, is how can we do both? How can we have sustainability of key anchor institutions while also addressing health equity. And then we can potentially, I think what you're suggesting is brilliant as well. How do we maybe bring together, because they're not all of the efforts are the same, but they it's sort of like, cases. They kind of bundle up in different ways. And this is not an attempt to make all of the efforts the same, but maybe to put like with like and think about how we get power. And I think a lot about the Health Services Research Institute for minority faculty, because we were benefiting from folks who had come before in a different generation, facing different challenges. So I can imagine that many institutions have centers where the leaders are being sort of batted about by changes that they have no control over. But how do we find a way to be leading that conversation in ways that folks can hear? So some of it may be about how we communicate our work, how we identify the most effective strategies. Some of those may be context bound. So I think you're right, it's about a serious set of conversations, not to make everything the same, but rather to measure and figure out how this ball gets moved forward in a way that is trustworthy and really meets the needs of the communities that we're connected to, that you've spent your lives connecting to in ways that it's important that these institutional forces not poison those relationships. So I just would say I would make the distinction, it's different from a strategy that's designed to accomplish a particular goal. It's really more about how do we let everyone bring what they have as long as we're focused on that same North Star.
I have a follow-up question. Which I'm having trouble speaking because I'm so inspired and so challenged by so much of what you said. So I'm going to try to make a coherent sentence about this. And thank you for your wisdom. So we're at a time as health equity scientists and health equity champions that it's a moment in time where most of us came from places where either our science was marginalized or our backgrounds were marginalized, or for most people, both are marginalized. All of a sudden, since 2020, the light is on us. There's money coming our way. Everybody wants an institute like this. There's now fierce competition for scarce talent in this area. And so we have this chance of growth. At the same time, we have to prove ourselves because we all understand that there's health equity tourism and there's health equity fatigue. And at some point in another couple of years, there's going to be another shiny toy people are going to follow. So how do you build this movement while you have this existential threat of how much time we have and how much time we have to build our shop, you build your shop, what are you seeing and hearing, and what are you thinking about how we move forward together?
I couldn't have put it better than you put it. And
It was a pretty coherent sentence.
yeah, that was yeah, I kind of dropped the mic. I don't know. It was a horrible set of circumstances that brought this to the radar screen. And while most of us weren't surprised by those things, and suddenly this new attention may have caught all of us off guard a little bit. But maybe it's already been a movement. That's why I don't know. Maybe it's already been a movement that was quiet and trying to make incremental progress, and then suddenly went viral. But that has the potential for the work to morph in ways that might have unintentional consequences. So I don't actually know. But you're right, it's a moment in time. And how do we realize that, this isn't Rush's money. In a sense, there's a kind of collective, how do we have this multiplicative effect of all of these dollars that doesn't just sit in individual institutions, and is subject to the kind of idiosyncrasies of those institutions. So I don't know, I don't know the answer, but it's what keeps me awake at night. Because again, if it's really just a moment in time, things got worse in terms of health equity overall in the last few years, despite all of this investment. Well, that's for all of it. That was not foreseeable either. Well, COVID wasn't foreseeable, that things would get worse, whatever the insult. So I want us to have the conversation, if it's welcome more broadly. Even about where this, the source of these funds. How do we think about, what do we call this money that's coming our way? Is it investment? Is it reparations? Is it?
I have a follow-up question to the movement theme, and I'm wondering what the point about leading with hope and acknowledging progress that we've made as kind of part of starting the movement. What advice you have for people of my generation, people just starting their career in this space who perhaps because we don't have the professional memory of seeing how much progress has been made, and perhaps because it's our, I think, generational tendency to lead with rage and at the expense of kind of just speaking in our echo chambers. What advice you have for us to find hope in these problems that seem really hopeless?
Yeah, I appreciate that. I appreciate what it can feel like when you're working in a time in a place that feels like there hasn't been progress or it feels hopeless. One of the things I would say about the generations that have come after me is that you understand things that we struggle to understand. So you understand intersectionality. Like we struggled, right? So, right? I mean, the notion, and I encounter this when I encounter learners and teach health disparities, that the resistance to multiple identities, LGBT people identify as trans, it was such a hurdle to get past just these notions of race and gender that were calcified, ossified in old ideas. So you're carrying that forward. Those insights, when brought to scholarship and inquiry, are kind of light years ahead of what we could have accomplished in that space. So you may not know how bad it was, but we can tell you that you have made it to a place where the impact can be much greater. The question is, do you have the support to get there? Do you see a future, right, for yourself in this work? And that to me speaks to not only are there opportunities to learn new things, but what is the climate like that you are living in on the day-to-day, right? Because some of what brings me satisfaction is the things I can do, but a lot of what brings me satisfaction is the day-to-day environment that I'm in that embraces difference in ways that that remove the kind of assaulted nature of the past. So I don't know if I'm being convincing in terms of that, but I will tell you it is a reality that we're in. And you talk to your colleagues that you're in a different place, a better place from the perspective of the biases that you don't have to overcome, in my opinion.
Thank you, Dr. Rich, so much for all of your insight today. We've come to the end of the webinar session, but we can stay in the room. We still have it, for the evening. But
We actually ran over the.
yeah, we ran over a little extra, but our fabulous IT team was able to help us out and make sure that we have sufficient amount of time to make sure that we got all these questions answered. So thank you very much for joining us, and thank you everybody joining virtually.